yeah, even on young, thin people, you need to be looking for insulin resistance. I didn't get into this part of preventive medicine too deeply until the past decade. I wish that one of my docs teaching me had known what I know now and had pushed me to get an OGTT and insulin levels. Insulin resistance, it definitely does exist, despite what some people might say. It's an incredibly important and devastating disease process. There's a great video that hit the YouTube community again about a week ago because of Ivor Cummins. We'll talk about that in just a minute. It's a lecture given by Gerald Shulman, June 24th, 2018, I think, when he received the Banting Award for his work at Yale on understanding and helping us develop the mechanisms the biochemical mechanisms for insulin resistance. Dr. Schumann, again, is at Howard Hughes Medical Institute. He's been using a lot of magnetic resonance imaging to find out what's going on in terms of gluconeogenesis, development of new glucose from the liver, glycogenesis, development of glycogen in the muscle and the liver, and its association with insulin resistance. I first found out about it by Joe Riley. Joe Riley has mentioned many times he's a patient of mine. He's also a moderator and super moderator and admin on the forum channel. It was posted first by Tom Deck, I think. Tom is also a super moderator for the channel. And he's got some great points. He said, look, it's the best talk I've ever heard about insulin resistance. The long and short of it is that it's accumulation of fat in liver and muscle cells. It gets, and he goes on to say the detailed metabolic steps get deep and don't lose interest. Hang in there, and maybe just jump to 39 minutes section where some of the takeaways are located. I'm going to go a little bit more into details because when you start looking at the details from my perspective as a treating patients, helping patients first understand that they have insulin resistance and then giving them suggestions, giving them opportunities to treat this disease process, I think you might get a little bit of a different perspective on this Shulman lecture. He goes on to say, don't get too hung up on Shulman's affiliation with Big Pharma. Shulman is working with Big Pharma to develop something that might help uncouple the mitochondrial activity within the liver cells. That's something very interesting, neat, potential breakthrough for the future. But again, this video is not about that. This video is about other things that Schumann and his community have helped us discover about the disease process of insulin resistance, which we can act on today. How can you find this? Again, if you want to find it on our forum, you go to the PrevMed website, click more. When you do, you'll get a drop down. The first item on the drop down, it says blog and forum. Then you just click on the forum. Once you get to the forum, you can look for the Shulman talk on insulin resistance posted by Ivor Cummins, posted on YouTube by Ivor Cummins, and posted on the forum by Tom. Kudos to Ivor Cummins. As I've said many times, he's somebody that I really respect. He's an engineer. He's got significant interest in insulin resistance, diabetes. His tagline is the Fat Emperor, and I've wondered if that had to do with the old story about the emperor that had no clothes. Obviously, by the banner ad on his page, it does, and I don't know. I'd love to have a conversation with Ivor to find out exactly what that's all about. But here, let's get to the details. For those of you who just want to hit it quick, look for 5 minutes, and then move on. I'll give you the 5-minute summary. Some of the concepts and learning points and some of the things that we need to do to react to that are, number one, yes, insulin resistance is real. In fact, for a huge portion of the research that they've done, they used young, thin, otherwise healthy, sedentary male subjects that had IR, insulin resistance. Most of these male subjects were offspring of adults that had significant type 2 diabetes. So what can we get from that? Yeah, even on young, thin people, you need to be looking for insulin resistance. I didn't get into this part of preventive medicine too deeply until the past decade. I wish that one of my docs teaching me had known what I know now and had pushed me to get an OGTT and insulin levels when I was much, much younger. Because one of the things you'll find on these studies is that these young men will have totally normal OGTT results, oral glucose tolerance results. And if you don't know what OGTT or oral glucose tolerance test is, you can look. I'm not going to get into depth on that right now. It's just that you're challenging your body with glucose and seeing how your body reacts and metabolizes that glucose. One of the other both of these points are key. Do the OGTT and do insulin. Because as I said, these young, thin, otherwise healthy males, even if you did an OGTT, you would not have known that they had insulin resistance had you not gotten insulin levels. And I see that all the time. I probably see that in about 10, maybe 20% of my patients where they have normal glucose values all the way through an OGTT. But once you start getting insulin, it's taking two times the insulin, sometimes even more, to keep those normal glucose levels. What's one of the next things to learn? He mentioned several times about increasing triglycerides and decreasing HDL when you start getting into the liver components of insulin resistance. Well, what should we learn from that? Obviously, again, how many videos do I have on the triglyceride to HDL ratio? The triglyceride to HDL ratio is something that you can say, look, I can't afford to go get a $200 or $300 set of inflammation labs. Okay, but almost every one of us has a routine cholesterol panel. Look at that routine cholesterol panel. If your triglyceride over HDL ratio is elevated significantly over 1, you need to be very concerned. Be afraid. Be very afraid. And then, obviously, I'm being somewhat facetious, but you do need to be concerned, and you do need to focus on the potential for having insulin resistance. BMI or RFM. What BMI, body mass index, RFM, relative fat mass. For those of you who don't like BMI, he mentions multiple times in the lecture, and I'll cover some screenshots a little bit later on each of these concepts where he covers them in the lecture and the impact of these things on insulin resistance at a biomolecular level. Again, what's the medical upshot of that? If I've said it once, I've said it 1,000 times to my patients and on videos. There's nothing more important than the relative fat mass or your BMI, how much you weigh. I remember talking to a new patient who, and I get this almost all the time. One of my new patients had a BMI in the mid-20s, and he was saying he thought he maybe needed to gain a little bit of weight. No. And I typically get patients who have a BMI close to 30, and they think that is a normal, healthy weight. A, it's not. B, the low 20s are much better. And C, most importantly, you get a huge impact on your biochemistry specific to insulin resistance just by losing a few pounds. He goes through several episodes of research in that area. The next one is muscle cell insulin resistance is DAG driven. I won't go into what DAG is, but it's something very much related to fatty acids. And what it creates is lack of transport of glucose. So in other words, it's not the different cascades of glycogen development within the muscle or within the liver that is hampered with insulin resistance. It's the transport of the glucose across the cell membrane, the muscle cell membrane and the liver cell membrane. Now, why is that an issue, and what can we do with that? He showed, again, multiple episodes where simple things like exercise, 45-minute exercise with the legs, and it almost completely reversed the insulin resistance process for muscles. Obviously, resistance training is a big deal. We've talked about it multiple times on videos. I talk with my patients about it. One of the reasons I have legs separated out here is that when I talk about resistance training, especially with men, they tend to think about making big arm muscles. You know, arm muscles don't have, I don't care who you are, your arm muscles usually do just not have the mass that are going to impact your insulin resistance like your leg muscles have. So leg muscle work, insulin resistant, is critical for insulin resistance. I also mentioned CGM, continuous glucose monitoring, and CGM directed walks. We've mentioned multiple times, watch how your body reacts to different foods. And especially if you know you're going to take a carb holiday, it's okay if you decide to do that, but remember and think, if I have a pizza and beer, I don't usually have that, but a lot of people do, and that's the carb holiday for a lot of folks. If you do that, go out and take a half-hour walk after that, and try to schedule these things, and talk to your spouse or whoever you're having that dinner with. Can we go out and walk afterwards, because I want to make sure that I pull that blood glucose back down. Yes, it did talk about meds. There's a lot of focus right now on mitochondrial uncoupling within the liver specifically. He talked about that at the end, and that gets a lot of buzz in terms of a potential breakthrough set of drugs for the future. Yes, that's great. It's wonderful. But we also have some drugs now, both of which he mentioned, that are critical for insulin resistance management. One is just plain old metformin, the TAME study, targeting aging with metformin, and old Pioglitazone, Actos. These are medications that have been around forever. They've been used forever, and they're still very good for insulin resistance. I have a lot of patients that just don't want to take any kind of drug whatsoever. I understand that. But again, hopefully getting a little bit deeper into the details of these medications will help folks begin to maybe take a second look at these medications, especially if you have significant insulin resistance. Now, if you wanted to get the basics, those were the basics. I'm going to give you a little bit more details, though, for those of you that want to stay on the video. The first one is this. Banting. Who was Banting, and why were these series of lectures named after him? It's an award that's given each year by the American Diabetes Association. Frederick Banting. He and his supervisor at University of Toronto received and a couple of other guys on this team received a Nobel Prize for medicine in 1923. What they did was they, as well as several other people, began to realize that there was something in the pancreas, and maybe specifically even in the islets of Langerhans, that had to do with keeping blood sugar down and treating or keeping people from having diabetes. They took isolates from cow and pig pancreas, that was, cows and pigs that were being slaughtered for sale. And this is the dog. There was a fellow named Best that was working with them. This is a picture on top of the roof at the University of Toronto. There are a few dogs that they were, about a dozen I think, that they took the pancreas out of, and then gave them this isolate, this substance they isolated from the pancreas of the pigs and the cows. The first few times, the first 10 dogs died, but Marjorie lived. at least a few months. Now, then you go on to say, was that real, or did they leave some of Marjorie's pancreas in there? Did she actually die of infection? There's just a bunch of other critical stories. But the bottom line was that team won the Nobel Prize for discovery of insulin. I first thought that they were referring to William Banting. Those of you who have read the books, a couple of Gary Taub's books, Good Calories, Bad Calories, or Why We Get Fat and What to Do About It, may have thought of William Banting. The books start out describing an undertaker who was born in 1796, died in 1878. He was obese, and based on the advice of a Scottish doc, he decided to just cut all carbs out of his diet. He lost weight. He wrote this up, and that became the first popular publication on the low-carb diet. So it's still even a term today. People will ask, are you banting? When they do, they mean, are you doing low-carb diet? It turns out, at least Wikipedia says, William was actually a distant relative of Frederick. Now, let's go back into some of the details on that Banting lecture and what we can see in terms of medicine today, just dreams for medications for tomorrow. First, again, insulin resistance is real. Dietary carbs are problems. Triglyceride over HDL ratio is a big deal. And it's something, then after watching this lecture, you begin to understand why you see that on your labs. It is very much associated with ectopic fat. What does ectopic mean? It just means something that's not where it should be. That's all. And the ectopic fat that we're talking about here is fat in the muscle tissue and liver tissue. Those are both very much associated with insulin resistance. Now, he mentioned several times that fatty acids inhibit insulin-stimulated glucose transport activity. In other words, what they did was they actually incubated, and you can demonstrate this by incubating skeletal muscle in fatty acids. It begins to shut down insulin response. Now, the question that obviously comes up is, well, is there a way that you can decrease exposure to fatty acids? I don't think that's ever going to be practical. The body burns fatty acids. You get to the question about, well, should I quit taking exogenous ketones? Are those bad for me? I don't think so. Again, I think this is just something for us to be aware of. Something may come up with it in the future, but for right now, fatty acids is just part of our metabolism. You cannot eat oils and or fats and stay the same weight and never have your body exposed to fatty acids. Now, some people could theoretically get into, well, that's the problem with the low-carb diet. There are much bigger problems with high-carb diets. That's, again, I think most folks watching this channel will understand that. As we mentioned before, they've done research showing that just a single bout of exercise can reverse the abnormal pattern of carbohydrate storage in insulin resistance individuals. So again, as you see, that is a temporary, albeit temporary, it is an effective reversal of insulin resistance. So exercise. That's one of the comments that Tom Deck put originally in the comments that he left on the forum. This information is critical to helping us understand why exercise is so important. Fat transport normalizes muscle and liver, or fat transplant normalizes this process. Now, fat transplants comes into the same place that exposure to fatty acids comes. I don't see us doing significant fat transplants. They did them on mice, and they actually reversed this problem. Now, how about being thin and having insulin resistance? This is a picture of a 17-year-old girl that has lipodystrophy. Lipo meaning fat or oil, and dystrophy meaning inappropriately formed. In fact, you see little or no fat around her body, but she's got a protruding abdomen. That abdomen's protruding because of a grossly overgrown liver, and it's grossly overgrown because of fat. They're using leptin therapy and got a huge improvement. So again, that raises another potential. Well, is leptin therapy something for our future? Again, that's something that's a little bit beyond the scope of this video. Something that's not beyond the scope of this video and is just everyday practical blocking and tackling. If you're a doc or if you're a patient, you should be thinking about a patient with insulin resistance. Is metformin really that bad for me? And again, this helps you understand exactly how metformin works. There's been several studies, a group called Madiraju with the principal author have published a couple of times in Nature magazine. He mentioned a Nature magazine article in 2014, and I've got a follow-up article coming up in just a minute. Basically what they're showing is that up until these articles, it really wasn't that clear what metformin does. It does a lot of things. For example, it does impact the gut biome. However, what these guys think now is that it may be mostly due to inhibition of gluconeogenesis through a redox, oxidation reduction impact within the cells of the liver. I personally am skeptical, not so much that there's a major redox mechanism going on or oxidation reduction mechanism. I also think it's got more than one mechanism. And I think, for example, that gut biome mechanism is probably helpful. Now, multiple times in this lecture, he mentions FOXO1, TNF-alpha, and IL-6, interleukin 6. TNF stands for tissue necrotic factor. He mentions those a lot. Basically, I think the takeaway from that on this lecture is basically he goes into liver targeted mitochondrial uncoupling. Again, that's exciting. That's something that they may develop in terms of a whole new category of drugs for treatment of insulin resistance for the future. But as I mentioned here again, this is exciting. But this lecture is not just about the future. It's about understanding what's going on in our body now and doing some basic blocking and tackling, like keeping our weight at where it should be, decreasing our relative fat mass, decreasing carbs, or managing our carb intake, understanding the importance of muscle activity, understanding the importance of looking for something simple like triglycerides over HDL, and again, some very basic medications. Speaking of BMI or RFM, if you look at this chart, what you see is for folks that have BMI 30 or greater, they have huge amounts of fat in their liver. This reminds me of a patient that I have. He's a doc, and we helped him discover his significant insulin resistance. And one of the things he's pointing out is that he thinks there's a lot more to non-alcoholic fatty liver disease. And that's what you hear multiple times in this lecture. Very strong association with non-alcoholic fatty liver disease. And you can see it here looking at just this simple graph. For folks that have a BMI 30 or greater, they tend to have a lot of fat in their liver cells. That's what that means in the second side. The first side is these guys with the yellow bar. The second side is hepatic lipid content or liver fat cell content. Again, very elevated. Just a couple of more slides and we're about done. We mentioned metformin. We didn't mention Pioglitazone yet, the thiazine diones. These are medicines that have been around for a while. They were very popular about a decade ago. Actos, you may remember that. And then he goes in to show the exact mechanism. Basically, one of the things that the thiazine diones are doing is decreasing that ectopic fat that you find in the liver and muscle cells and redirecting that fat back to subcutaneous fat. Subcutaneous fat, by the way, is not the problem, does not cause insulin resistance. It's where you get that spillover of subcutaneous fat into muscles and liver. So again, pardon me if it's been a long video. It was a great lecture. I can't help but thank Ivor Cummins again for his discovery of this video. You know, I went and looked. I found the video on his channel after Tom Deck posted it, and I went to look to see how he discovered that video, and I still don't understand how he did. There's a lot of information on the web about the Banting awards and the Banting lectures. But again, my kudos to Mr. Cummins for finding out that specific lecture. It was a great one. If you've made it this far, thank you so much for your interest. So I'm very excited to announce we now have a membership page. Now, what is that? That's the one place where you can go and access all of our digital products. It starts off with a few free things, like a lot of infographics, which help you understand the basics of insulin resistance, cardiovascular inflammation, and other key concepts on how to prevent heart attack and stroke. The next free item is the intro and first chapter of the book that we're writing on plaque. The standards of medicine just aren't doing very well right now in terms of the #1 killer and disabler, plaque. We don't do a good job of measuring it. We don't do a good job of monitoring it. And there are better ways. So that's what this book is all about. Again, go in and get a look at the intro and the first chapter. And if you've purchased the cardiovascular inflammation and IR courses, thank you so much for doing that. You purchased those at a time before we had them totally cleaned up, and we've cleaned them up now. And they're available for you right there on the membership page. Hit the link below, register, and go in and take a look. Look forward to seeing you there. Thank you.